Good afternoon, everyone. We'll just wait a couple of minutes while we have everyone join the webinar. So we might get started then. So good afternoon and welcome to the Australian Centre for Value-Based Healthcare webinar, where today we will be discussing the TAC's value-based healthcare journey, outcomes that matter in road trauma. I'm Emma Hoban, the Policy Manager at the Australian Healthcare and Hospital Association, and it is my pleasure to be with you today. We are all set for a very interesting discussion this morning, and I'm sure we'll inspire some great questions. We have a dedicated Q&A section at the end of the webinar, but feel free to ask your questions as they occur via the Q&A function at the bottom of the screen. I will now hand over to Liz Cairns, Head of Strategy, Sectors and Research at the Transport Accident Commission in Victoria, to provide an acknowledgement of country and introduce today's discussion.
Thank you, Emma, and thanks to AHHA for hosting the webinar. I'm in New York at the moment, and I'd like to acknowledge the Lenape people as the traditional owners of the lands on where I am today, New York City, and acknowledge and respect the enduring relationship that exists between First Nations people and their traditional territories. And an acknowledgement of the lands on which TAC headquarters rests. That's the Wathaurong people in the Geelong area, and I'd like to pay our deepest respects to them as the traditional owners of the lands and to their elders past, present and emerging, and also pay our respects to any Aboriginal and Torres Strait Islander peoples who may be here today. I can get you to go to the next slide, Emma. Thank you. Look, this is just a bit of a contextual slide, and it places value-based healthcare in the context of the TAC 2025 strategy. That was approved by our board towards the end of last year, and we're in detailed planning in terms of execution and sequencing planning, as you do with strategies. You can see the strategy here. It's a bit like a sort of summary version on the page. The purpose of TAC is to care for the lives of everyone who travels on Victoria's roads. We have both a prevention side that we're very well known for, and we also have an insurance side. Our role is to support people who are injured on Victoria's roads through road trauma. Our vision, obviously, to be the safest place in the world for road travel. If Victoria was a country, we'd be about 5th in the world, and you'll see some slides in the presentation that talk about the work that the TAC and other road safety partners have done. Our mission is stated there, and then we've got four strategic directions. As I said, one is road safety and prevention. That's in our legislation, and we've picked 3 others in consultation with staff and with our board. One of them is obviously value-based healthcare. Now, that's not absolutely new to what we've been doing, but it really focuses on the importance of the quality of healthcare treatment for TAC clients and making sure that we are getting value for money, and that that intervention and that treatment and support is not only more motivating for practitioners, but absolutely focused around achieving the outcomes that are important to the client. That links very closely with the insurance part of our business, which is Direction 3, our next generation claims management model, and we're doing co-design at the moment and bringing those two things together. They don't kind of sit separately. Value-based healthcare is that's a new initiative for us to pursue, but we've been around since the mid-1980s, and we've been supporting injured Victorians in all sorts of different ways over that time, but this is an opportunity to bring the two together. And clearly, that's everything that sits under both of those 3 directions: prevention, value-based healthcare, and claims management has got a very strong focus on digital and data enablement, and that will be a significant investment for us. We've called out 3 strategic enablers at the bottom. Rework, that's TAC language for effectively what work looks like for us in a post-COVID world. So things like a permanent adoption of hybrid working practices, and all the support and leadership that's around that. That's not only for us, obviously, but everyone else who we interact with externally, including clients and our providers. Our brand, as I said earlier, very, very well known, both nationally and internationally for the work that we've done in road safety and injury prevention. Interestingly, less known about the insurance part of our business, the claims management and the support that we provide for injured Victorians. So the brand is beginning to bring those two aspects of our business together. And we've made a deliberate call out, as many other organisations have, around a commitment to ESG, environment, social and governance. Interestingly, a lot of organisations kick off with environment. We're making a very heavy investment into governance, so things gender equity, disability action plan, and our first reconciliation action plan as well. So I'll pull up there. You'll hear from the team in future slides about what TAC does, and then we'll get into the nitty-gritty about how we're approaching value-based healthcare. Thank you.
Thanks, Liz. And so for those of you, my name's Olivia Pantelidis. I'm the Senior Manager of Value-Based Healthcare here at the TAC. You've just heard from Liz Cairns, who's the Head of Strategy, Sectors and Research. Liz is an absolute powerhouse when it comes to social insurance. She's worked across New Zealand's accident compensation scheme, community disability and aged care services, and she's also focused with the NDIS. And she relocated to Geelong actually to become the manager of the inaugural Victorian NDIS trial site, and then became the General Manager of Operations for the NDIA before moving to the TAC, where she headed up our Independence division and now heads up our Strategy, Sectors and Research division. I'd also like to present Cam Lucas, who is the Senior Manager of our Actuarial Services at the TAC. And prior to joining the TAC, he worked as an in-house actuary at EML. And one of the things that I really liked about Cam is when he put his bio together, he said to me that his 3- and 5-year-old girls describe his job as graphs and meetings, and that is actually pretty accurate for Cam. You'll then hear from Cassie Citron, and Cassie's got over 10 years experience working at the TAC, and these are in areas of client research, business intelligence, health compensation and disability research and organisational strategy. Cassie is an absolute gun when it comes to our client outcomes data, and I'm really looking forward to her discussion around that information today. And last but not least, Lydia Stojanovsky, who's the Senior Project Manager of our Value-Based Healthcare program here at the TAC. And Lydia's got over 20 years of clinical experience as a registered nurse and operational and strategic leadership roles in public health, injury management and compensation schemes. Next slide, please. So the TAC has a really long history in public health promotion. We've been focusing on road trauma for over 30 years, and the results have been impressive, but there's always a push to do more. You can see here that the TAC started in 1986 and the significant decline in road trauma that has been impacted by the way that this organisation pushes boundaries. We work closely with our road safety partners, and we really aim to halve road deaths by 2030 and ultimately reach 0 deaths and injuries by 2050 to become the safest place in the world for road travel. And we're not afraid to challenge long-held societal beliefs around what is acceptable. And as for those of you who know our road safety campaigns, we've been unafraid to push those boundaries to try and effect a public health response to the important messages around the impacts of road trauma. The burden of disease is significant when it comes to road trauma, and we're committed here at the TAC to continuously push to reduce and minimise that as much as possible. And the way that we do that through our public education is through evidence and research and establishing significant public health responses to reduce those fatalities and serious injuries. Some examples of those are wire rope barriers, enforcement for drug and alcohol, and also as well significant investments in road safety infrastructure. Next slide, please. So the TAC, just a brief overview of who we are. We're a Victorian state monopoly-owned compulsory third-party insurer. So no one else like us here in Victoria, and we were established as part of the Transport Accident Act in 1986. So for those of you who are Victorian, you know that your premium is paid through annual vehicle registration, and that is a core component for the TAC. We have an independent board and minister for the TAC that we are entirely accountable to, and approximately 18,000 new claims per year and around 50,000 active clients per year. There's approximately 900 staff, and we are scattered across Victoria. We have our location here in Geelong on Wathaurong land, as Liz had said, with some location sites around Victoria also. We're a no-fault treatment, support and compensation benefits scheme. So regardless of fault, you are entitled to receive specific benefits. The common law damages are for those not at fault and who have been deemed to have a serious injury. And also, as well as I spoke about previously, we have a significant role in accident prevention. I think some of the important parts that not everybody knows about from a road safety perspective is the significant work that is done to support accident prevention, even from the perspective of our vehicles. So how do you prevent that? Through ESG, auto brakes, ensuring that the accident doesn't even happen to begin with is also a core component of accident prevention, as well as work into schools to support our younger drivers and educating them about the importance of safety on our roads. Next slide, please. So what do we do? Well, accident prevention, I've already spoken about, and we work across a safe system approach with our road safety partners to ensure that we are ensuring that everyone is having a safe journey on our roads. And rehabilitation is a really, really big part of what we do, and we work with our providers to maximise return to work, return to health and independence for those who have been injured. There's a claims management component to our work as well, which is about how we support people to make the right decisions at the earliest time to get accurate compensation and also understand the care pathways that are available to them and the services available. Our claims management area is really the large engine of this organisation that supports all people who've been impacted by road trauma and have a really, really important role to play. From a financial management perspective, we work with the government to ensure the scheme is viable, sustainable and represents value for money. Given that we are taking a premium from your registration, it is important that we are deriving value for money for that. And from a scheme design perspective, we work with our stakeholders to ensure compensation is suitable, just and effectively delivered. And as an organisation, there is always work that can be done to better processes and better systems, and always working to drive better the outcomes for our clients and the way that we support and work with our providers and our other key stakeholders. Next slide, please. So now I'd like to hand over to Cam Lucas.
Great, thanks, Olivia. So when I was asked to talk briefly to this webinar, I was asked to discuss the funding of the TAC. So what I'm going to run through are two short slides on basically where our claims costs come from and what we spend that money on. Olivia mentioned there was a significant part of Victorians' registration costs. And there's a line item on that registration bill that Victorians get sent about the TAC charge. They don't get this breakdown that I'm giving you today, but it's a significant amount of money per year. And Victorians who want to have a car registered don't really have a choice between insurance providers. We're the statutory monopoly in Victoria. So the premium that we charge needs to cover the cost of accidents that occur in that year, the cost, the claims benefits that we'll pay for the lifetime of those claims. So while we have a significant portion of our claims are relatively short term, somebody will have an injury of some sort in a car crash and they'll recover. There's also a significant portion of our claims that will remain with the scheme for years and up to the remainder of their life, depending on how catastrophically injured they might be. So as an actuary, I'm interested in ensuring that the projections that we make about the future costs of the scheme are accurate, so that we can ensure that the scheme is sustainable. So here's an estimate of what the benefits that we'll pay from the premium that we'll collect from motorists in 2022-23. So the break-even cost. So the estimated break-even cost of the TAC insurance that we provide is about $380 per vehicle. And you can see what we spend that on. So a little over 25% of that is on expenses. So that's the one that I've broken down into three there. So they're not claim benefits, or there's some small ones in there, but generally these aren't benefits payable to a client for either their treatment or for compensation. these are made up of the administrative costs of running the scheme. So you can see that's a segment there. The road safety work that we do. So you can see what proportion of the premium we collect actually goes to road safety, and that's in the form of both sort of the road safety marketing that you might see if you're a Victorian, but also the road safety investments we make in the infrastructure of the state. So one significant one was the road safety barriers we implemented. And you can see how of that $380 break-even cost per vehicle, we spend another 25% on treatment and income, and another roughly 25% on common law benefits. So that's lump sum compensation that somebody not at fault and seriously injured in an accident will be entitled to. And there's other claim costs and long-term care costs. So it's a significant impost on Victorians, and we need to ensure its value for money. And that's, I think, where value-based healthcare plays a role in ensuring that this money that we spend annually for every vehicle is efficiently allocated. So I might move on to the next slide. This is a slightly more broken down version of a couple of those benefit types there that you saw. So I haven't broken them all down, but you can see our lifetime care costs over the life of a year's worth of accidents, and the treatment costs, total treatment costs over the life of a year's accidents. And instead of showing it as a dollars per policy, essentially, or dollars per vehicle registered, here I've shown it as a total dollars per year. And you can see that that axis on the left is in billions of dollars. So each year the TAC is projected to incur just under $1.5 billion in claims costs to pay out on those claims that will be incurred in the year until they're fully run off. So it's a significant sort of impost on the scheme, and ensuring that we spend that money efficiently and get the outcomes that we need to get is a focus for the scheme. I'll also mention that we also have a significant outstanding claims liability. So while this is our new claims incurred each year, we also hold a reserve, essentially a liability on our balance sheets for past accidents. That is, I think in December, about $19.1 billion. So that's the amount that we think is still outstanding on our existing claims to pay out. And that's spread slightly differently to what you see on the new claims cost. But importantly, where we can spend money more or less efficiently than what we've currently projected to spend will also have a sort of a significant impact, or the potential to have a significant impact on the long-term sustainability of the scheme. I think that's time to pass on to, is that back to Olivia now, or maybe on to Cassie to talk through the next slide?
I think it might be me. Thanks, Cam. So essentially, thanks for walking us through all the finances, Cam, because I think that's really touching on the part of our TAC's legislative obligation around providing efficient service. So really, we have to understand our costs and our scheme sustainability to get to that. Another part of our legislative obligation is around providing effective support to clients during their recovery. And so this slide is really showing you TAC's journey of how it has worked to understand client outcomes. As the client is the centre of what we're trying to do here, the outcomes are really important for our understanding of how we can be providing the effective service that we want to for our clients. So essentially, we started this journey way back, potentially even a little bit before 2000, but definitely internally in around the year 2000, where we started our client experience survey. Following that, we also started funding external trauma registries in about 2001, 2003, which collected a mass of inpatient hospital data as well as longer term outcomes for clients. This then informed TAC's, again, internal survey around the client outcomes study. So we started then internally getting our own client outcomes data for a cross-section of clients. And then that effectively built into a longitudinal study in 2012. And so really that was kind of taking the next step from all this cross-sectional data that TAC has been collecting to actually collect longitudinal data over time. All of this has then sort of helped inform what was at the time the TAC 2020 strategy and our understanding of client cohorts and our sort of segmentation model work, which I'll talk to in the next slide. But really, we were starting to reach that point at the in the 2020 strategy where we're going, cool, we've got a lot of outcomes, we've got a lot of cost. How does this all come together? And I think that's where TAC became more aware of value-based healthcare and what that really offered TAC. And we could see that we've kind of been on this journey towards it for such a long time, but really starting to get more frameworks and models in place about how TAC could really solidly bring the finances and the outcomes together to truly understand what is value for our clients. So this is in 2019, we started work to get an environmental scan of outcomes frameworks and value-based healthcare models. And then this sort of then built into TAC doing a value-based healthcare maturity assessment on ourselves, and with EY support, providing us with a roadmap of how to develop our internal maturity. There's a lot of other little bits and pieces thrown in there along the way, other outcomes registries and such, but you know, we've been on a bit of a journey and we continue to be. So I might jump to the next slide. Cool, thanks. So under the 2020 strategy, we really used a lot of the longitudinal study data to better understand our clients. And because this was really such an asset that TAC had built at the time, it gave us the ability to predict outcomes. So the study followed up clients at 3, 6, 12, 24 months, and even up to 48 months after the accident. We were then able to use the earlier data to predict outcomes at a later point, which we hadn't had the ability to do before. So using this data, we were able to have a bit of a look at the factors that influenced outcomes, and so that then informed our view of what we sort of termed to the big six. And you can see here in this slide, that's really captured under those complexities. So the 6 complexities under there was informed by our big six work, but then the questions within that, and specifically the questions with little asterisks, we used when we built a predictive model using the longitudinal study, and found that we could essentially our 6 questions up front that could give us a pretty good indication of what client outcomes would be later on. So we then, over the next sort of couple of years, worked at embedding this tool into practice. So shifting it from just a purely research-based predictive model into a sort of operationalization of a client segmentation model. So essentially what we started to understand was that there's this group of clients that got their outcomes better pretty quickly, and what we've sort of labeled them as is rapid recovery clients, and then another cohort of clients that are really taking much longer to achieve outcomes, so we call them supported. So what you're then seeing in there off to the right image is really how that triaging worked. So we ended up using a digital first sort of approach, so we would approach clients, as many clients as we could digitally via an SMS. If clients weren't responding, we would then follow them up with a phone call and see if we could ask them a few questions about sort of who they are, where they're at, sort of quite immediately after the accident. So the other thing that we did really have to work through was, again, from a research perspective, we were asking questions at 3 months. So there is a stage of stability that happens there, but what we wanted to do in practice is as early as possible try and get clients into the right area of business so we could get support to them as quickly as possible. So we really had to understand how this tool would work in practice. So there's probably a lot more that I could unpack about the needs ID model, but essentially it is a model based on predicting client outcomes that we've then used to triage clients around our business. And under this new strategy, so that Liz talked about just at the beginning of this presentation, we will be looking at ways that we can effectively enhance this model and its ability to predict outcomes. So I might move on to the next slide. Cool, thank you. So essentially this is just giving you a little bit more, looks like we've got a little bit of a compression happening here of the slide, giving you a little bit more detail about who these clients are. So that rapid recovery cohort, we established that it was about 80% of our clients, they would recover quite quickly. And then we would put them into a service model that really required minimal intervention from us. And so typically that was trauma and acute services needed in there. The top layer that you're seeing there of all the bubbles is how we've understood our supported recovery clients, and that's about 19% of our clients with a bit more complex injuries, complex need, and we then tailor our supports for those clients and take a real whole of life approach, because there's often quite a lot happening for those clients in their lives, and we do expect that their recovery will take a little longer. Just the dots underneath that are reflective of what we would call our independence clients, and so these are really 1% of our clients that are catastrophically injured, and we've had a segmentation model for these clients for a very long time because of the severity of their injuries. It is an injury-based model, and like I said, we expect them to be with us, with the TAC, for the duration of their life, most likely after their accident. And so then the supports that we have to provide for these clients look a little bit different again, and there are models in there around sort of contemporary disability practice and enhancing the client's choice and dignity. So I might pull up there and hand over to, I think it might be Lydia or Lydia. Yeah.
Yes, thanks Cassie, and please make sure, I'm sure you'll have lots of questions to ask Cassie around that needs ID model as part of our Q&A at the end of this. So reflections and key learnings from our previous strategy is that the needs identification segments are working accurately, and we are very confident that our populations are correct. We've taken an evidence-based approach through our data and research, and we're seeing the gains from that and building on that. One of the things we did learn though is that we really did too much too soon. In an attempt to remove red tape for our providers and our clients, it resulted in some significant financial performance implications, and it was also an opportunity for us to really understand the role of essentially pulling several levers all at the same time and the broad impacts that that can create for us as an organisation and for our stakeholders involved with us. We were also held back by our foundational systems, some old technological solutions that we had that we also experienced through COVID that needed significant uplift and has been a challenging process for us. We've understand that we need to build on those foundational systems. And we really didn't understand the value or the outcomes derived from our clients. One of the questions and the experiences that we asked ourselves is, do we really know what we get for what we pay for? Do we really understand the outcomes that our clients achieve and the cost involved in that? And we couldn't answer that question. And so for us, it was really that iterative step towards understanding those externalities and the relationship that they have on a scheme's performance, but also as well the impact to our clients as well. Next slide, please. And so then that is how value-based healthcare became a component part of the 2025 strategy. It's been an important step to be able to establish a framework around what we've already been trying to work towards over the many years as an organisation to get and drive better outcomes for our clients. It's really a foundational set of principles for us as an organisation to live by and move towards, to be able to really understand the outcomes we get and the costs derived for those outcomes. Next slide, please. So how will we transition to value-based healthcare? Value-based healthcare has a simple theory, we could argue. You know, value equals the outcomes and experience over the cost to deliver that. But simple in theory, complex in implementation. And how does an entire organisation transition to something like this? And so we brought in EY to work with us on developing a maturity assessment. And a maturity assessment was a really core component part because we wanted to establish a process for our transition that was realistic, measurable and achievable. And we really wanted to establish a baseline for our organisation. We are an ambitious organisation, so how do you create tangible steps and a clear roadmap to bring you back to that baseline and understand what you're achieving for such a long-term strategy of transition to value-based healthcare? Because for us, the ultimate goal is the best outcomes possible for our clients and really knowing what we get for what we pay for. And we had to understand how mature we were as an organisation to be able to do this. And so we worked closely, as I said, with EY on this maturity assessment, and we based it fundamentally on the quadruple aim and the principles of value-based healthcare. Because as an organisation, the quadruple aim around outcomes, experience and optimisation are a fundamental part of our core business in general. And so when I've been asked about what value-based healthcare is and how it translates to us as an organisation, I bring people back to this, is that we want to support the delivery of high-value care by partnering with our providers to deliver better client outcomes, a better experience for our clients and providers, and for the best cost. And so we took 4 key domains of how we would focus our attention for that transition. And so our understanding that our levers as a payer is around our pricing and purchasing arrangements. So how do we use those first and foremost and understand the steps to get there? And so we focused on client outcomes and how we would embed those into our pricing and purchasing arrangements, how we would work with our providers to support the delivery of safe and quality care. As an organisation, what is the capability that we need to understand now and in the future to transition to become a value-based healthcare organisation? And what's the data and technology requirements that we will need to build over time? And once we had this established, we'd be able to set a clear direction that holds us accountable along the journey. And I have to say that it is personally exciting and absolutely daunting at what lies ahead of us. But this maturity assessment always brings us back to what we need to do. Next slide, please. So where do we start? How do we start? And I know that that's a question for so many people. And Deb Cole, who was the chair of Dental Health Services Victoria, who just this year won the Value-Based Healthcare Prize in Europe for the work that they've done there, has said, you just have to start. Don't be paralysed by thinking about that. Just start. Because for us, our ultimate goal is about supporting our clients to achieve the best health outcomes possible. And that drives everything at the TAC. And so where do we start? Well, we're starting with a series of specific cohorts, clients, and we'll test the principles of value-based healthcare. Because the 2 key areas that Elizabeth Teisberg, who co-authored the value-based healthcare theory, has said is that you understand a population segment and you understand a sphere of influence. And so we've been able to identify some population segments and our sphere of influence in relation to our stakeholders involved with that population to test and learn our approach. And so I'll hand over to Lydia now, who will talk more about our pilot programs.
Thanks, Olivia. So I do have the pleasure of working with some really intelligent women, Mariana Cassini and Jodie Cook here at the TAC, to start our value-based healthcare journey and understanding what and where our opportunities are to start to influence our organisation as well as the external market in making outcomes something really important and valuable part of the services that we deliver and pay for our clients. So the two models that we're going to be testing our value-based healthcare principles in are VOC and PAIN. And so why have we chosen those two? Well, for us, returning people to participation in life activities prior to their accident is something we focus on doing, and work is one of those. And so since 2017, we've been iterating on a vocational services provider model. We've worked on understanding what the need is and, understand that good work is good for you, and the health and wellbeing outcomes that having good work delivers to clients, not just by attending work, but more globally and broadly in their lives and their relationships and their fulfillment in their life. We're really clear on the agreed outcome, which is return to work in some form of capacity. We are very clear on the data that we use and how we use this data to understand complexity and risk, stratifying our clients to determine what level of intervention they might need from a vocational rehabilitation provider to support them with. And we've also worked on redesigning how we pay for services. So we've got a bundled payment option that we base on complexity. And then we've also introduced an incentivisation outcome. So when a client returns to work, we pay the provider an outcome payment to reward them for the effort that they've put into getting that client back to work. And then we've also started surveying clients to understand their experience of returning to work. And so what we've discovered is that there's a really good clear pathway on and how clients can get back to work. And now what we want to do is understand where the value in that journey and pathway is. And so what we'll be doing is we'll be working with our vocational providers in the coming months to start co-designing with clients and providers to better understand what good and efficient and effective return to work would look like. And so pain is another pilot group that we're going to be looking at. And the reason we've chosen that is we have a collaboration with WorkSafe Victoria, where we do have a network pain management program where we have 5, 6, 7 contracted providers. And we've been working with them for some time on collecting outcome data through EPOC at the University of Wollongong. And that data is at a point where it's becoming quite enriched, and we've got some really good insights as to what types of client cohorts attend those programs, who tends to do well, who tends to not do so well. And now we'll be using that information to explore what opportunities we have in understanding what types of intervention and care clients of different cohorts would be benefiting from. And the advantage from a TAC perspective is that whilst we have this enriched EPOC information on outcomes, we also have an entirely end-to-end view of a client's journey. So from accident all the way through their time on our scheme, we see the different types of services that clients are using. We fund their healthcare, we fund their medication, we're involved in supporting them to return to work or return to education. So we've got that luxury of having an end-to-end view, and now our opportunity is to work with clients and providers to understand the value in that pathway, and also where there is potential opportunity to remove some of the waste and who we would be looking at working with and doing that with. And it's daunting because pain is so complex, but it's also exciting to think that we'll have the opportunity to influence some of the outcomes and some of the experiences of our clients as well as our providers. Next slide, please. So this slide talks to some of the feedback we receive from our clients. So we survey our clients to get an understanding of their outcomes and experience. And you can see there we've split it with our rapid recovery cohort and our supported recovery cohort. And 67% of the clients interviewed tell us that in rapid recovery that pain is one of the largest complexities that's getting in their way of recovering and getting their life back on track. And it's not just acute pain, it's chronic pain. So pain that's longer than 3 months in duration. And then you can see there in our supported recovery client cohort, it's also quite high. So what we know from this is that we are not alone. The schemes and our in other jurisdictions and our providers that we speak to are all experiencing similar situations around pain being a significant burden and impact on clients' lives and their outcomes. And it's not surprising when, you know, I think it was 2015, the second leading cause of the total burden of disease in Victoria was related to back pain and back problems. And that was only second to coronary artery disease. So it's not just an issue that happens in compensation schemes, but it's a broader community problem. Next slide, please. This slide is the beginnings of a client pathway that we've started to map. And so in the paying cohort, as I said earlier, we're really trying to understand what our client's journey looks like. And we've got the luxury of having that information because we are funding that treatment and intervention for the client. And so what we're using this pathway to do is to then identify and work with our providers to identify where the low and high value care is being delivered and how we can become more efficient. We try to really demonstrate with this slide the variation in experience and outcomes that you see, which is where there's a bifurcation in the timeline that clients will experience. And it largely is because of different services they access, different providers that they will access that service through. And so whilst you may not ever be able to eliminate pain, there's definitely an opportunity here to reduce the variance and work on getting some more consistent practice across professions. What we see too is that there is an inefficient use of resources and a lack of integration across the healthcare spectrum. So we've got siloed approaches, the way we fund care. Clients typically tend to, just get, I guess, pushed around or just, follow the instructions, but aren't necessarily being informed healthcare consumers. And so where's our opportunity as a funder of healthcare to work with providers and clients to improve that health literacy component? We're also really keen to understand how we can translate the most recent best practice and evidence-informed clinical guidelines or management frameworks to within our provider groups to get them to deliver care that is informing clients of managing pain very early on and not letting it just be a management of a physical condition and then a client deteriorating to a point where they require an extensive network pain management program quite late in their recovery. We want to try and target something a little bit earlier. We think there is great opportunity there. And we also want to be able to understand how we can risk profile clients at that early stage, which is similar to what Cassie was speaking to about earlier around, we've got some really great data and information around what leads to a poorer health outcome. And so how do we use that earlier on in a client's journey and share that with the client or a provider to then empower them to make treatment decisions or informed healthcare decisions around how they want to work with their providers to manage their pain or the services they may choose to access. And another opportunity is that integrated pathway. So how do we get providers talking to and working with each other to support clients rather than working in a very siloed approach that we have today? Next slide, please. So no surprise that the EPOC data shows us that the majority of our clients that go through the program actually have back pain as their primary area of pain, so almost 50%, which is a significant portion. And we understand and know that these clients are likely to not have to not go back to work. They are likely to be using polypharmacy, medications, opioids. They are typically having low value care where they're having multiple radiological investigations or ongoing passive therapy, and they can escalate, as you would have seen in the previous slide, into having some quite invasive and intensive surgeries that may or may not deliver them a good outcome. And also there's established evidence bases around clinical guidelines for the management of back pain. So we think, like I said earlier, there's an opportunity to consider about how we actually implement those best practice guidelines. Next slide, please. So what we've seen from a scheme perspective is that we've had a demand and cost growth in the number of requests and types of imaging that we've been getting. We've also seen surgery spinal surgery increase, and implantable pain devices increase. And unsurprisingly, now we're also seeing medical cannabis become something that clients with chronic pain are asking our schemes to fund. And so what we know is that when we don't support clients with good health information and getting good care and treatment, we see them become entrenched in their pain condition, and that results in them disconnecting from their previous life participation. We see them increase their healthcare utilisation. They stay with our scheme for longer because they're just not sure about what they need to access and what's giving them benefit. And what we've seen too is we see a plateauing or a reduction in our client outcomes, return to work rates, and our client experience scores. But it's not just about the cost, as I've said earlier, like that's an inherent thing around value-based healthcare, but we're also concerned about clients not being able to access quality pain education at the right time. We're concerned about the failed physical therapy and pain management in primary care settings, and as well as the failed back surgery, and what impacts these have on a client's overall health and well-being. So it's more about the burden of disease of poorly managed care and that broader societal impact. So it's not just about cost. And as the TAC and the organisation who pays for the healthcare of our clients, we have an obligation to make sure that the services that we're funding for our clients is getting the best healthcare outcomes for them and their families. Next slide, please. So what we've done now is we've currently started mapping out as you saw, the client journey, and we're doing a lot of review of the literature and research to identify where opportunities are, and we've limited to 3 things right now. So improving our risk profiling of clients, and what do we do with that information, and how does that support clinicians in the healthcare services that they deliver. We're looking at healthcare and consumer literacy. So what information do our clients get from us or from their providers that actually empower them to be informed healthcare consumers, and how would this impact their recovery? And the last thing that we're looking at is around that integrated treatment pathway. And so understanding about which services could work together, or how we could design service delivery to enhance clients' interaction with healthcare and providers' interaction with each other to get good client outcomes. So we're going to test against these 3 principles. This is our early thinking, and there's still a bunch of work that we've got to do around co-designing with our clients and providers, but this is the beginnings of where we think we're going to go. And so, as I said earlier, that early identification and prevention approach, that empowering our consumers and using evidence-based and proven clinical guidelines to see if we deliver care in a different way that actually changes clients' outcomes. I think that's me. I think I'm handing over back to Olivia now.
Yeah, thanks, Lydia. Really, this is just the beginning for us. We wanted to share the beginning of our journey. We wanted to open it up to questions and know that we're learning along the way, just as everybody is on this value-based healthcare journey. And we're really looking forward to what that looks like and how that will evolve. So I'll hand over to Liz and Emma for closing comments, and then open up for questions. Get your questions in the chat, or get yourselves ready for lots of questions. Thanks, Liz.
Thanks, Liv, and thank you to the TAC team for presenting. Look, I'd just like to thank you for spending this time with us. As you can see, we've had a long-term commitment to client outcomes, but this is our first entry and quite a deliberate entry to value-based healthcare. So we're very aware that we're at the beginning of that journey. I think as a social insurer, we do have some advantages. You know, we know a lot about some of our clients. They stay with us for a very long time. We've got a lot of information and data. Like a lot of organisations, we don't use a lot of it. And this is really, value-based healthcare is bringing us a bit of a discipline. Importantly, the ability to look at clients and stay connected with clients and clients' outcomes on a more longitudinal basis gives us a real advantage, and I think quite an opportunity to contribute to value-based healthcare as we build our maturity, as Liv has said. What interventions and what supports work with clients, what's sustainable with that client over a longer period of time, sometimes their lifetime, as Cam has talked about. What's the impact of the achievement on that outcome on consumption of services, on things like general health and wellbeing, and in time, not only our services, obviously, things that we fund, but also the supports that that person may need from the broader service system. So we're really interested not only in building our own capability, we're very, very aware that we're at the beginning of this journey, and really value the support of organisations like AHHA and other partners as well. So thank you. Thanks for coming. I'm looking forward to a really interesting Q&A session.
Thanks, Liz. Thank you. So I've got a couple of questions. So the first one has come from Sam Parker. Sam's actually put in two here. Is there any examples of any other state or country that serves as an exemplar, i.e. who's doing it well? Sam, so the interesting thing about value-based healthcare is that it is a journey for everybody in the context of their own context. So if you wanted an exemplar within an Australian context, Dental Health Services Victoria are very much the exemplar, and I spoke about them winning the award. They have been on this journey for about 5 or 6 years now, and they have established some really excellent transitions to value-based healthcare around the way that they fund preventative oral health, and also the transformation in relation to outcomes and care with the providers. So I encourage you to look up Dental Health Services. You can also go to the Australian Centre for Value-Based Healthcare website through the AHHA, and they have lots of excellent examples as well. New South Wales Health, from a governmental and state perspective, are also the most far advanced within Australia, but there are a lot of examples within the hospital context within America, and as well as through the NHS in the UK, which are some of those examples. Another question that I have here, so excuse me whilst I work through these, is there a specific model that we can incorporate into our day-to-day practice? So I will actually hand over to Lydia to discuss this one, and maybe Elise, can you give us maybe a little bit more detail in the chat about what you might mean about that, Lydia?
Thanks, Liv. Sorry, just trying to work out the tech at my end. Couldn't get myself off mute. Yeah, is there a specific model that you could incorporate into your day-to-day practice? I guess what we do is, in my team, I've got a team of passionate healthcare and health program design people, and then I've got a scheme that I work within that also wants to get outcomes. So we make sure that we're constantly thinking about what does the consumer or what would the consumer want or need, and so really putting ourselves in the client's position and really taking an approach where we think about the impact of what we're doing or what we want to do and how that will impact a client's experience, a provider's experience, and a client's outcome. So, for example, you know, we could build a solution that's fit for TAC, but then when it goes into the community, you know, when we evaluate, it doesn't work, and that's because we haven't actually worked with clients and providers. And so, I think if you think less about what the model is, but you actually bring in who the model is going to be affecting. For us, it's clients and providers, and you actually try to design with them. Yes, it takes a lot longer and it's really hard work, but your model's going to be so much more enriched because you're actually going to be designing something that the people want and need and will then interact with. I think that's probably the best thing I can do, or advice I can give you all, and talk about our experience directly.
Thanks, Lydia. So I want to go to the Q&A. A question from Judy. Hi, Judy. And I'm going to hand this one over to Cassie to answer first, and then Lydia may want to add something to this. What are the questions for assessing complexity and stratification?
Yeah, cool. Thanks, Liv. I'm not sure if the slides are going to be circulated afterwards, but I think it was one of the second slides that I spoke to laid out the complexity factors. So there's 6 complexities. The first is around pain, physical health, mental health, recovery expectations, the service environment, and then the accident response. And so hopefully if you're getting the slide pack, in there's questions that are asterisked underneath that. And so they're what we say are the first 6 questions that we asked. And then all the other questions are supporting questions that we ask as a follow-up. So if you need any more details, I'm happy to provide.
Thank you. I might go on to then one of the next questions here. What have been from Kim? Hi, Kim. What have been your learnings to bring the medical pain specialist profession along for the value-based healthcare journey? We're only just at the beginning of that now, but Lydia, did you just want to briefly answer that question?
Yeah, sure can. So we are currently pulling together what our co-design requirements and engagement plan will actually look like. And part of that is understanding who's wanting to engage with us. So we will be putting out some expressions of interest for people to be part of some of these working groups. So we don't actually have I don't have a response into what our experience has been like just yet, but it's absolutely front and center of any of the work that we'll be doing about engaging that profession.
Thanks, Lydia. I've got a question here from Nick. Hi, Nick. What's the TAC sphere of influence mean for how TAC might move from the pilot phase into other areas of delivery where the influence might not be as strong? That's a really great question. And so really, Nick, from our perspective, you actually, when you consider the sphere of influence, we chose VOC and pain because we have established parameters already aligned to the principles of value-based healthcare, contractual arrangements, agreed outcomes, agreed performance measures. And so the way that you would actually do that is by continuously reassessing where that sphere of influence is, so that you're not stepping into a space automatically without being able to work collaboratively. Now, that's going to look different and that's going to change and shift. And we may step into an area where we might need to roll back a little from or change and adjust. And I think that's probably one of the most interesting things about this journey is that we have a pathway forward, but because this is a co-designed pathway with clients and ultimately what they want from their outcomes and with our providers, what that's going to look like and how that will move will take varying shapes, I think, along the way. So I hope that answers your question. Now, next question I've got here. So asking around direction 4, around data and digital enablement and how that fits into our timelines. Well, that is actually in relation to us as an organisation. As I spoke about, our systems, our foundational systems are somewhat old and antiquated. So how are we actually going to change and adjust us as an organisation? How will we use all of the rich data that we have in a meaningful way? How will we actually have the digital capability to not only support the work that we do, but the way that we engage with our clients and providers? So it's a significant underpinning of our strategy more broadly. Now, I've only got a couple of minutes left. So how is the package with integrated biopsychosocial approach for pain delivered? And this is from Susanna. Hi, Susanna. So Lydia, I might hand that one over to you, and we might have one for one more if there's another question left.
Yeah, thanks, Liv. I'm not sure if the question is around our current network pain management program or our future work in the model. So I'm not really sure how I actually answer this, Susanna. But in our network pain in the future, okay, thank you. So that's a really great question. So probably one of the things we didn't discuss is that, so we don't have the answers. So in true value-based healthcare, we are adopting a co-design approach. And so we are going, that's what our provider and client engagement will be about, is we're using a program logic methodology where we are working to understand the needs of our clients what outcomes matter to them, what their experience and what our providers' experience needs to be, and then filling in the middle bit about, well, how do we actually do that? And so I don't have an answer. I'm not a clinician that delivers a paying service, but those are the types of people we want to help us design the solution. And like I said earlier, if they're involved from the beginning around co-designing, they are the experts. They are the people sitting opposite a patient trying to get them well. I'm hoping that they will be able to help us with those answers.
Thank you so much for that. So we are actually at time now. So we have got one question that has come in from Anna around what plans there are to evaluate the trial outcomes. Now, Emma, are we allowed to go over, or do we need to actually formally stop to answer this final question?
You can do the final question, that's fine.
Excellent. All right, Lydia, back over to you for the question around evaluating trial outcomes.
Yeah, so what we're going to be doing is we are using a plan, do, check, act sort of rapid cycle approach. So we'll be iterating continuously. It won't be a 2-year plan and we'll evaluate it in 2 years' time. So the project team is really set up to test and learn and then understand scalability. So I know that was one of the questions earlier on as well. So we will be keeping this front and center and communicating this. We're really keen to work with partners who are interested, absolutely wanting to create this whole value-based healthcare sort of little subgroup that we can all learn from each other. So we don't have an evaluation plan just yet. It's something the team and I are working on, but it'll be short, sharp, iterative changes rather than a 2-year piece of work that we'll evaluate and then have something to deliver in 3 years' time.
Thanks, Lydia. And thanks everyone for your questions. We will organise the slides are more than available, and there will also, the session is recorded. So I'll hand over to Emma now for the final close, and thanks everyone.
Thank you everyone for your attendance today, and thank you very much for the TAC team for joining us and sharing your value-based healthcare journey. So if you're interested to know more about value-based healthcare and the Australian Centre for Value-Based Healthcare, we host regular webinars on topics related to value-based healthcare. Our next one is next Monday, the 4th of July, and it's on the topic of digitally enabled value-based healthcare in colorectal cancer. It will feature a discussion of Cabrini Health and the Alfred's experience of implementing a global standard for patient-centred outcomes. We also have newsletters, which you can subscribe to on the Australian Centre for Value-Based Healthcare website, and you can register for our events on the AHA website under the events section. Thank you very much, everyone, and we look forward to seeing you at one of our future webinars.